Very good, thank you. And thank you for the invitation to speak here and for that introduction, Dr. Jacobson and Alyssa, for all of your help. One of the most important things I'm going to say today is that my views do not express or represent the National Department of Veterans Affairs. Also do not represent the National Pharmacogenomics Program. These are only my personal views, and I have no conflicts of interest. Okay, as we jump into G6PD, I do have an informal poll question. How many of you, from what you learned in pharmacy school or from other medical school or other places, felt like G6PD interactions were going to be everywhere and were going to be kind of like quicksand waiting for you to show up? Any hand raises there, or I don't know if I can see reactions. I'm not seeing them, so maybe not. Or maybe I'm the only one who felt like G6PD was going to be this major clinical issue coming up. All right, well, let's get started. So G6PD is an enzyme that metabolizes NADP to NADPH. It is a rate-limiting step. As you can see, glucose comes into the cell through a transporter, and this is an erythrocyte or red blood cell. It is then formed into glucose 6-phosphate, and it requires G6PD to form the next step in its pathway of glycolysis. But in addition, NADP requires G6PD to change to NADPH. NADPH is a very important part of our red blood cells because it protects the red blood cell from oxidative stress and from breakdown by free radicals and lysis of the red blood cell. So if we don't have much G6PD, then we're not going to make much NADPH, and that red blood cell is not going to be very well protected. There are about 230 known variants for G6PD that exist, and one thing that I was reminded of when we first started working with G6PD again is that medicines aren't metabolized by G6PD, so it's very different than a lot of our other PGx variants and genes that we work with. Most of them are either metabolism enzymes for medications or transporters, but G6PD doesn't interact with the medications directly in that way. So why is it a problem if someone does not have enough G6PD? The oxygen-free radicals and hydrogen peroxide that are caused through the interaction of medications that can affect or cause oxidative stress can't be removed if there is not G6PD, because NADPH is the process that helps change hydrogen peroxide into water, and so then it is freely released, and water is not toxic to the red blood cell, so it is the path that we want to have happen with oxygen-free radicals and hydrogen peroxide. Infections can greatly cause G6PD deficient patients to develop red blood cell lysis. Fava beans are another source of that, particularly fresh fava beans, which we don't see as much in the US. And then there are some drugs that generate hydrogen peroxide and oxygen-free radicals. So those with G6PD deficiency are more prone to drug-induced lysis, leading to hemolytic anemia. There is also oxidation of hemoglobin iron to form methemoglobin, and the NADPH also helps with this process in patients who are not deficient in reducing it to ferrous form of iron and avoiding that risk of methemoglobinemia. So in patients who are deficient, they are at increased risk of methemoglobinemia. How do you identify someone having hemolytic anemia? Usually it's about 2 to 4 days after the infection starts or they ingest a drug with a strong risk of this. With fresh fava beans, it could occur within hours of the ingestion. Jaundice or yellowing of skin or eye whites. Dark urine is another common symptom, and back pain or abdominal pain. And what you see as signs, you see the hemoglobin has a abrupt decrease. You can see the if there's a peripheral smear of the CBC, there will be some unusual cells like bite cells and blister cells and poikilocytes and microspherocytes. And then the creatinine may have an increase, and urine analysis will have some abnormalities as well. How to treat hemolytic anemia: you stop the offending agent, treat the trigger. So if there's an infection, you definitely want to treat the infection. If a transfusion is indicated, then that should occur, and aggressive hydration. The duration of the illness is about 1 week, and that is because new reticulocytes start forming right away. Those take about 5 days, and the new reticulocytes will have more G6PD than the ones that were killed off, the red blood cells that were killed off. So even if that ongoing stressor is there, usually you see an improvement in symptoms within about a week. How does one inherit G6PD deficiency? So it is our only PGx gene that is an X chromosome related recessive gene. If a person only has one X chromosome, then they inherit G6PD deficiency from their mother or their egg donor. And that would be in cases where a person only has one X chromosome. So like what we consider a traditional male has one X and one Y chromosome, or Turner syndrome. They are often classified as females, but only have one X chromosome. So those people, if they inherit a deficient X chromosome from their mother, they will absolutely have G6PD deficiency. If a person has two X chromosomes, they inherit one from their mother and one from their father or sperm donor. And if those are both deficient, then they will have G6PD deficiency. If they are not both deficient, which is typically the case, that they have one inherited that's deficient and one that is normal, then it's difficult to say if they have G6PD deficiency. There's only one X chromosome that's active at a time in each individual cell, and they can have a different ratio of how many are expressing the X chromosome that is fully functioning for G6PD versus the ones that are G6PD deficient. So you have to do an enzyme level, and that can change at points in people's lives and depending on different factors. So folks with two X chromosomes are generally females, or it could be a male with Klinefelter syndrome who has two X chromosomes and a Y chromosome. And this is the CPIC guideline that shows a little bit more that a normal patient has either one X chromosome, that's a normal variant, or they have two X chromosomes and they are both normal functioning. A deficient patient will have either only one X chromosome that's deficient, that's one of these variants that has deficient function, or they could have two X chromosomes that are both deficient. So if both their mom and their dad had deficiency that they passed along, then that would be the case for someone with two X chromosomes. There is a category that's also called a class 1 that's a deficient with chronic non-spherocytic hemolytic anemia. And these people have lower levels of hemolytic anemia throughout their life. It's a chronic illness for them. And that would be a person who has one X chromosome and inherited one of these severe class 1 type variants, or a person who has two X chromosomes and got two of these, which would be extremely rare. Variable is what we typically see with females if they have one X chromosome that's a normal variant and one that is a deficient variant. And that's where we need to do the enzyme testing to further clarify. And there are a few variants that they're uncertain of the function. And again, in those folks, you'll need to do an enzyme G6PD quantitative test to determine what the patient's actual function is. So in December of 2023, the VA PGx panel changed from an 11 gene panel to a 16 gene panel. We cover about 10 of the 230 G6PD variants. A couple of those are the normal variants. A became a normal variant, I believe, in I shouldn't quote dates, sometime between 2014 and the 2022 update of the CPIC guidelines, and B has always been considered a normal. And then the deficient variants that we cover include the A- ones, Asahi, and Mediterranean, and some others. So the VA pharmacogenomic testing model, from its inception around 2019 through the end of this year, has been a model that included preemptive, targeted, and reactive testing. We were fortunate to have a donation of PGx testing from the Sanford Foundation and Sanford Health. So that allowed for patients to self-refer for PGx testing. Many of our sites do offer testing to patients newly coming into the VA primary care through their new patient medication intakes. And we even had outreach events and attended different veteran fairs and offered testing. And any prescriber and any veteran could have testing, regardless if they were on any medications or on none. This allowed our providers to get some experience with PGx testing, and our pharmacists, as well as get as many people tested as possible. So we were grateful for that donation. As that is going to be reaching an end, we are moving more into targeted and reactive testing through workflows, toolkits, indications, and we have population health dashboards for people who would be good candidates for PGx testing. Through adding G6PD testing to our model, to our panel, we've found that we're having a lot of incidental findings of G6PD deficiency, or in some cases, previously known cases where we're confirming that. We have little role in the VA for targeted and reactive testing because a lot of the medications that can cause severe reactions aren't ones that are planned necessarily, and there is a 2 to 3 week turnaround on the time of the results. So it may be useful to know for down the road, but most of the cases we're finding are incidental findings. The rigors of military training also make it unlikely that a person with the chronic non-spherocytic hemolytic anemia would have been in the Army or other Department of Defense service or branch and been able to make it through the rigors of basic training and other trainings. So we're unlikely to run across those folks in VA care. G6PD testing has been ongoing for a very long time in the U.S. Department of Defense. Back in 1981, the Department of Defense issued Instruction 6465.1 that required G6PD screening for all personnel entering the armed services and those on active duty who have not previously been tested. This is because there were cases in the Vietnam War and prior to that where people were given Primaquine, a malaria medication, because they were either entering an area that was malaria endemic as part of their deployment or developed malaria. And so they were having a lot of cases of people developing hemolytic anemia. They did not specify what type of testing needed to be done at that time. They did reissue this bulletin, although it had never been rescinded as far as I could tell. It's been ongoing since 1981, but in 2015 they did reissue the bulletin, and in that procedure did list that education, medical education to the patient who is identified with G6PD deficiency is required. The DoD G6PD testing must be in the service member's electronic medical record or service treatment record. Most of the testing that I find is enzyme quantitative testing. Very occasionally we run across that they had genetic testing, but a lot of times even the results I see will just say deficient and don't say what variant they had or even what method of testing was done. Also, results prior to the computerized records are difficult to find. They may be in scanned documents, or they may be in a warehouse somewhere or something. So a lot of times it's difficult to find, depending on what years of service they entered and when they were tested for G6PD. We do have a portal for looking at DoD records called Joint Legacy Viewer. The content does depend on what time frame they serve, so it has all their current VA records, which is helpful if they're have had care at several different VAs. If they recently had military service, then it's also super helpful. If someone had a sleep study last year in the military, we can look that up easily. But if someone, if it was your grandpa that served in World War II, there's going to be almost nothing in the records that aren't in the regular VA electronic medical record, because the records were not electronic during their term of service. And if you're working in a VA and ever looking for those G6PD lab results, if you're looking in the lab widget, I've found that doing a search for glucose-6 with the parentheses can be helpful, or searching for G6PD. But like I said, a lot of them aren't found in the lab widget because they're in scanned documents, because they were prior to the electronic medical record. Veterans have military ID tags, active service members have have military ID tags. Typically they're silver. The purpose is to help provide the wearer aid in the field in case they're injured or pass away. And typically those have the name. It used to be the Social Security, now it's their Department of Defense ID number, their blood type and RH factor, and their religion. Those started back in the 1900s, and even as a requirement, but even in the Civil War, people would have their name and phone number, or maybe they didn't have phones in the Civil War. I should be careful about that. Their name and maybe their family member's name or something like that in written on a piece of paper and pinned to their uniform, or there was different ways of people being identified because so many people were dying, and then to be able to identify those people easily and notify their families. And even I saw reports that back in the Spartan days in Greece, they had some form of identification tags. Around the year, I'm not sure. I think it was 2020, but it might have been sooner than that. They started producing these red, actually it was 2017, they started producing these red medical tags. Those have the name and DoD ID number, and for patients or service members who have allergies, like a medicine or an insect allergy, that is printed on there. If they are on a medication that's really important for them to keep taking, like insulin or Coumadin, that would be listed on there. And if they have some certain permanent medical conditions like diabetes, G6PD deficiency, seizures, if they need to wear glasses or they need hearing aids, those are all printed on those. So if a person had G6PD deficiency prior to those red tags, it would have been on their silver medical or their silver ID tag, or dog tag as they are nicknamed. But these days, if they have that, it would be on a red medical tag, and they have those in addition to their silver medical tags. So what do we do when we get a result back, getting the PGx panel in the VA these days, and it shows the patient is deficient or variable, such as a heterozygous person with 2X chromosomes? Typically, my process is to assess the records for prior G6PD testing. I do keep in mind that if they were born prior to 1960, they're unlikely to have been tested. And if they're born prior to 1980, it's going to be hard to find those records because they're probably not in the computerized lab records. If it's a heterozygous female, the testing results at the time when they were in the military may be not necessarily inaccurate, but they will reflect the patient's state at the time of that enzyme testing, and so it would be recommended to retest them now. And in all of our newly identified patients, they do recommend retesting with enzyme testing to confirm the finding. And then there's a suggestion for referral to medical genetics or hematology for genetic counseling. So we are starting to come across more cases where there's incongruent DoD and VA G6PD results between the genotype testing and the enzyme testing that occurred. This may be because a lot of the testing done in the DoD was enzyme testing, and in the VA it is the genotype testing. We are only testing 10 of the 230 variants. The mosaicism that can happen with females or people with two X chromosomes, which could be an unidentified genetic condition such as Klinefelter's, also lab error. In our cases, it's not as likely that it would be due to a transfusion or low hemoglobin or low white cell count, since we're not doing targeted testing, and these are usually patients who are getting the PGx panel as preemptive testing and haven't had a recent hospitalization or other condition. But that is a possibility, certainly if you work in a hospital and you're doing targeted G6PD testing. In 2022, the CPIC updated G6PD guidelines were released. The 2014 guidelines included guidance on rasburicase, although in the supplemental guidance there was other medications that had been reviewed or that had been reported as having G6PD deficiency concerns for hemolytic anemia, and they did an assessment at that time, but it was kind of beyond the scope of that guideline to specifically make recommendations on those. The 2022 guideline was greatly expanded to include all those medications, about 50 of them, a little less than 50, I think actually, that were ever associated with possible G6PD hemolytic anemia risks. They reviewed the evidence on all of those. They classified them as high, medium, low to no risk or not assigned. They provided drug-gene interaction guidance on what to do if a person needed one of those medications or was on one of those medications. And one of the things I've really appreciated in learning more about this guideline is there's a video on the CPIC website that Dr. Relling did that provides a lot of the background and also how they assess these, how they develop the classes, and some orientation to get guidelines, and even provided a lot of in-depth analysis on different G6PD variants and how they have also dealt with this issue of people having differences in their genotype testing versus their enzyme testing, and some studies that they've done. So highly recommend that if you are interested in this topic. Oh gosh, I'm getting low on time. So the medication risk categories are medium, high, and low to no, and NA. NA ones are ones that there's not sufficient evidence or there's significant differences in the evidence. Low to no are ones that are mostly case reports and that there were extraneous factors like infections, and that there maybe even have been studies to show that there's not a reason to avoid those medications. In mediums, you do want to use careful monitoring and test the enzymes in those who you're uncertain of their status, like variable or indeterminates. And with high, you do want to avoid use in patients with G6PD deficiency. And that is just the guideline there of those no reason to avoid in the low to no risk medication guidelines. And finally, just going to pick on aspirin. You'll probably see why real soon, but the only drug label that currently includes aspirin that I could find in PharmD was in the Swissmedic guidelines or package insert. For aspirin, it does say that patients taking acetylsalicylic acid could have hemolysis induced, and that factors associated are high doses, fever, or acute infections. So I believe that is the end of my didactic slides. Any questions? We're